Thanks for all speakers for their excellent presentation and their being in time. So I want to start with the last one. I like your study very much, so it's very good. What do you think, how you make it possible that you have this multidisciplinary approach? You have always a team around you for doing metastatic spine surgery, or how is it managed?
Actually, our institute does not have multidisciplinary team.
Okay.
Yeah. So yeah, you know, to establish multidisciplinary team need manpower, and so we have to make effort to establish. So yeah, from the result of this study, we want to we need to make good team for treatment of spinal metastasis.
Okay,
thank you.
Thank you.
So we'll start with some questions from the audience. So regarding the first presentation, here comes the question: could the cell saver also be safe in tumors like lymphoma and leukemia? So.
Yeah. So that's a perfect question. In our study, we actually did show that for metastatic spine tumor surgery, in terms of all kinds of various tumors subgroup, primary subgroup, leukemia, lymphoma, it seems to have worked. In this sense, although the treatment case for lymphoma, depending on the oncologist, may be first chemotherapy rather than surgery up front. So it really depends on the kind of requirement for surgery of the patient. But in this sense, it showed that in our study, in terms of all different kinds of metastatic spine tumor surgery, it does help in management of the blood loss overall. Okay. Yeah.
There's one question from the floor, please.
Yeah. Naresh Kumar from Singapore. I'm the senior author for the first paper. It's very obvious for lymphoma and myeloma and leukemia. You can always give it. It's a blood cancer. So it's for epithelial tumors. I think it's very, very important. So this study was more to look at epithelial tumors, but myeloma and lymphoma are already included in that. Now, my question is to the third author. You looked at your wound complication rate 18%, which is 18%, isn't it, in the group which had complications? So that means if you look at the overall complication rate, your wound infection rate is about, wound problem rate is about 10%, which is fairly high. I thought in the present day, I would be very surprised. I go to visit Japan quite often, and I found that the reasons, so any particular reasons why your wound problems were so high, and was there a correlation to open surgery or MIS surgery? Did you have any differentiation between them? Because in my hospital, the wound complication rate is 4% for major tumor surgery.
Thank you for the question. So this is a multi-center study. Okay. So this complication includes not only major wound complication, but also include minor wound complication, which can be treated by conservative therapy.
In that case,
I think that's why the complication rate here.
It's good to divide them then.
Yeah.
Okay.
Thank you for your question.
Yeah. Thank you for the question. And again, for the first speaker, because it's a highly interesting topic, so we have had for decades, I would say, we have the credo not to give cell salvage blood back to the patient. So it's very interesting that you're starting doing it. And my question is whether you use a leukocyte depletion filter or whether you do a radiation of the salvaged blood, or...
Yeah, perfect. So we actually use, in our institution, there's actually a patient blood management protocol that we work with the anesthetist. So actually they are the ones doing all the blood management work while we are working on the surgery intraoperatively. What we use is a leukocyte depletion filter.
Okay.
And we have showed through our previous biochemical studies that using this exact filter, the tumor cell load is either non-negligible or not even present. Negligible meaning that because it's passed through the filter, the cells kind of lose its receptors, and the cells cell membrane actually deforms, so they're not really tumor cells anymore, even after passing through it. Yeah.
Okay. So I have a question to the second speaker. With your flow void, is there a correlation to angiography? So is what you see in MRI the real, or is it something you, are learning in the beginning?
Okay. Thank you for your question. And we haven't showed the relation between an angiographic assessment and intratumoral flow void in this presentation. But in another study, we examined the angiographic grade and the intratumoral flow void. And in another study, the correlation between intratumoral flow void and angiographic assessment was shown. And we would like to show you the results in next EUROSPINE meeting. And we think that more than 2.5 millimeter of intratumoral flow void diameter means hypervascular tumor type by angiographic assessment. And so we think that more than 2.5 millimeter cases has a risk factor for massive IBL in metastatic spinal tumor.
And have you also looked at the epidural spinal cord compression scale, the ESCC? Because a couple of years ago it was found that the grading of the ESCC was highly correlated with the blood loss, so perhaps it might be actually the same thing, or do you think it's a different topic, that the flow void versus the compression of the spinal cord? Have you looked for that? In your study, did you examine the ESCC score?
We haven't examined the ESCC score in this study.
Okay.
And I just want to know from your perspective, we always talk about hypervasculated tumors. Is anybody using preoperative embolization if it's possible, if it's not an emergency and you have to go to surgery? Or is it like uncommon in your treatment?
Some papers have reported that the histologic tumor type has discrepancy in terms of vascularity. So we think that the intratumoral flow void is more useful and reliable vascularity marker than histologic tumor type.
Is any one of you others using preoperative embolization in your tumors?
Yeah, actually, I think my senior author, Prof. Naresh, and our team in Singapore, we actually use pre-op angiolar embolization quite often. We did a patient blood management kind of study also that showed that pre-op angiolar embolization actually helps to improve and reduce intraoperative
And
blood loss.
which type of patients you do it?
So classically, it will be the higher we know the higher vascularity subgroup. So
Okay.
breast, thyroid, we know that this patient bleed a bit more. But often than not, if they can go for the pre-op angiolar embolization, if there's a slot and it's non-emergent, usually we do that, especially if the kind of cord compression has been kind of subacute in these patients in this sense. Yep.
Okay, thank you very much.
Thank you
to all of you.
Yeah. I think my
Just one quick comment. Somebody asked about whether to use leukocyte depletion filters or not. My recommendation, as I'm the brain behind this, all the study, you don't have to use it. Enough papers, if you go through my papers, you'll find that there's evidence even without leukocyte depletion filter, you can use it directly. So it reduces, it makes the theater team accept, if you have one more step in it, there is a little bit of resistance to use. So you use cell saver directly, transfuse the patients with that, and no change in survival, no change in recurrence rate.
Thank you for your comment. We
Sure.
have to go on. Thank you.
Thanks.